to read objectives, detail. All these little things off. So starting with immunity, we have that normal physiological response to pathogens that enter our body, how our immune system should respond to them. We may have suppressed immunity or excessive, which is exaggerated. So people that have allergies, things like that, that would be that exaggerated, hyper-exaggerated response. So you have innate immunity since birth. This is not going to be on your test, so don't be memorizing this stuff. This is just, again, your review of this stuff. Acquired immunity, which is broken down into active and passive. So what is something with active acquired immunity? How do we get it? Yes, so your vaccines. What about passive acquired immunity? Yeah, so it passes on, so mother to baby. May even be like artificial things like the IVIG we discussed yesterday. That would also fall into that. Hypoimmune responses, so our suppressed immunity, when did we see that? Yeah, like steroids, what else?
Chemo.
We'll talk about that today. What else? What did we just cover 2 weeks ago?
Patients.
What is it?
Leukemia patients.
Yeah, so our patients with cancers. So people that are taking chemo, things like that, or like she said, leukemia, because what's leukemia do to our bone marrow, our white cells, our immune system altogether, it suppresses it. What about a hyperimmune response? So what are some of the examples of that? So these things, so when our patients have anaphylactic reactions to things, that all falls there. So our immune system is kind of doing too much, working over. 3 primary protective functions. So it protects our bodies from the invasion of microorganisms, removes dead or damaged tissues. So we kind of talked about that with a normal cell. They are supposed to die when they need to. Our immune system has to clean those up so that they just don't linger in our body. And then recognizes and removes cell mutations. So what does that mean? So we kind of reviewed that when we discussed cancer. So we have cell mutations. Usually our body can recognize that. They can get rid of those mutations. But if they can't, then what happens? We have cancer. So those things can happen. 3 lines of defenses. We talked about the skin. So it's our biggest defense. So when we talked about some of the infections last Monday, we talked about MRSA, things like that. So if we get a break in that skin barrier, then we're more at risk for those infections. And then we have our defenses here, right here, our immune system, and then our antibodies, which is from our B cells. Immune system organs, so bone marrow, thymus, spleen, tonsils, adenoids, appendix. So this always kind of, a lot of people get their tonsils and adenoids out. Why? Yes. So, for instance, my son, when he was born, didn't sleep for the first 2 years of his life, and I thought, oh my gosh, is this what a boy is like? My girl slept fine, my boy didn't. So finally, he couldn't breathe almost. So they took his adenoids out because they said, okay, he's just keeping congestion. We don't know why. We're just going to take his adenoids because he's not old enough to take his tonsils. Took his adenoids. He sleeps great. However, he snores awful. His tonsils are almost kissing. So now, eventually, you'll have to take those out because he gets strep all the time. So now we see this. So there's a reason why. And these are good because they trap pathogens so that it doesn't go down into our lungs. However, when they constantly get sick, they're not so helpful. So we can remove those things. When do we discuss this?
With cancer.
With leukemia, yeah. So our myeloid and lymphoid cells. So our pathways. And those are the cells, and we've already went through that. I'm not even going to go through that again. But now you can see how some of these lectures go together, they interrelate. So our B lymphocyte responses. Deleted a lot of stuff. So our B lymphocyte responses, they make antibodies for us. So our plasma cells, and we also have memory cells that fall under that B lymphocyte. Our plasma cells, we talked about what condition? It was in cancer. Yeah, it's one of the cancers we talked about that affects the plasma cells. that affects the plasma cells. So our plasma cells, what our plasma cells do is that first, so the first time a pathogen enters our body, a brand new one enters our body, the plasma cell is the one that responds to it. It makes an antibody for it. It kind of takes care of it. The bad thing about plasma cells is they don't really last long. The next time that same pathogen enters our body, the plasma cell's memory cell, you got it. Memory cells remember it, and they put out those antibodies in response to it. So they're quicker, they last longer in our system. T lymphocytes, we have several. So we have a cytotoxic T cell, which kind of kills those cancer cells. They're the ones that take care of those things. They're the killer of it. Then we have helper T cell. You need to know this one. We're going to discuss it today. The helper T cell is the CD4 cell that we'll talk about a lot. This is the one that when a pathogen enters, it says, oh crap, something's going on, and it alerts the B lymphocytes. So it's that trigger for the B lymphocyte to respond. I don't know if y'all ever watched Magic School Bus a long time ago, but they had what I remember it because I was so fascinated, and now I know why because I went into nursing. But I remember it went, like, the little school bus went into the body. They saw the different cells and things. I thought that was so neat. I need to show my daughter that because she'd love it. But that's what the helper T cell does. Then you have a So suppressor T cell suppresses the function of these. Why do we need to suppress the function? What about those hyper-exaggerated, like people that have really bad allergies or anaphylactic, they're allergic to every antibiotic out there? They might not have very good suppressor T cells because that's why it needs to suppress them so that things that are helping us, like it helps our system, but it actually causes these to flare up and go against it. So that's why we need that suppressor T cell. You don't really need to know these two, but definitely the helper T cell. You need to understand its function. And the reason why isn't understanding what it does, it's just whenever you see the disease processes that we're going to talk about today, you understand why it's happening. So our exaggerated immune response, I don't go into because we're not really talking about that in today's lecture. But what you have is just the different types of hypersensitivity. So people that may have like allergies to bee stings would fall into like a type 1 category. Maybe those that have maybe autoimmune diseases could fall into type 3 and so forth. Suppressed immunity, so you have a primary, so something is going on with the cells themselves. So it's nothing causing it, just something's going on with the immune system itself. Secondary is a loss of immune function due to another disease. So it's secondary to something else. So it could be leukemia, it could be somebody's taking cancer, or taking cancer, they're taking chemo. Consequences. So obviously, bless you.
Thank you.
So we have immune suppression, so you have serious health problems with the immunocompromised individuals. Things that we do see, cancer, we've already talked about that. What are some other disease processes or other things you may think of on the floor that suppresses your immune system? You said the certain medications, what else?
Methotrexate, like arthritis.
What about transplants? Yeah, because transplants, we're suppressing their immune system so they don't reject it. So that is one thing, and that's kind of one of those things that's not necessarily negative as why we're, suppressing their immune system so that they can have that transplant, but it may affect them later on.
Would RA be under that?
Mm-hmm. Yeah. And then you have exaggerated immune response. So all these people that have crazy allergies, eczema, asthma, all those things. Risk. So who has suppressed immunity? Like ages.
Older,
And very young. Yeah, so the very young, the very old. So in between, we seem to be okay unless there's other, underlying issues, but really, you get very young, very old. Non-immunized states, so maybe those that don't really have the vaccines. Environmental factors may have a play in this. Chronic illnesses, HIV, diabetes, cancer, pregnancy, does that suppress your immunity? Yes, it does. That's why everybody gets sick during their pregnancy. High-risk behaviors, genetics can play, but I see more genetics in the exaggerated immune response. So genetics, exaggerated immunity, is there a certain race that has this? No. It's really just genetics, environmental, and they also say if you have really bad allergies, like wherever you live, if you eat a lot of honey, local honey, it helps with your allergies. I don't know if it's true or not, but that's something to think about or tell your patients about. History. So allergies, exposures, you want a detailed history about what's going on with the patient. You want to look at their immune functioning, how, we may even do blood tests, all these things which fall down here into the diagnostics. You see the allergy testing. A lot of people get allergy testing, especially if they're allergic to a lot of medications. Obviously, we don't want to flare them up or make them have anaphylactic reactions. Then you have suppressed and immune, which we've already kind of went over. I'm not going to keep eating that. And then organ function testing, due to like if we do have immune suppression. So your primary prevention, secondary prevention. So what can we do to help our immune system? What are some primary prevention things?
Nutrition.
Yeah. What else?
Vaccines.
Yeah. Vaccines is a huge one. What about high-risk behaviors? Like education on those things. What about secondary prevention? What are some things? What falls under secondary prevention? Screening. So HIV screening, pregnancy. So we do a lot of testing during pregnancy, just to keep mom and baby healthy. This came from your all's concept book. You don't do that. Okay. Now's when you're going to start studying. I did that one. Now I don't know how. So HIV is a retrovirus that integrates into what cell? The CD4, that helper cell. Now we see why it's so important. It loves the cell. Once it's machinery on the inside, that's why it attacks it. So what happens when HIV takes over the cell? Can it trigger? Can it respond like it usually does to pathogens? No. So what we have is severe immunodeficiency. We have opportunistic infections, and we have malignancies that come from the cell being altered. It is, what is it?
Severe immunodeficiency. What was
They're on your list. Oh, I'm sorry. Yeah, right there. I was just repeating it. So you have a worldwide epidemic, okay? Without treatment, it can transform into AIDS. How quick it does that really depends. Like if somebody is very cautious, takes medication like they should, they're not as risky, or maybe doing like, if somebody continues to do like IV drug use, things like that, then are they going to be more at risk for it? Yes, turning over. Yes, it is. So those are things that we kind of educate our patients on. This cell, I do not ask you to memorize it. What I do ask you to do is when you're studying, really understanding what this does, because when we move to medication, every medication goes with a phase of this. Okay, so there's areas that the medications block. There's plenty of areas of the medications to block so that we can reduce the HIV going into these beautiful cells. So viruses are intracellular parasites. What does intracellular parasites mean? Yes, it attacks the inside of it. So moving back, I wonder if this thing will work. Oh, I didn't turn it on. Okay. So right here is your HIV cell, okay? So what we have are these things on the ends of this are called glycoproteins. This is what docks onto the receptor of the HIV, okay? So this is the HIV, this is what is utilized, what docks onto the cell.
It's the protein, right?
Those are also referred to spike proteins.
Yeah. Yeah. So that's what you see whenever you're looking at that under microscopes and things. So inside the virus, it contains its own genetic material, which is reverse transcriptase. Okay, so they have RNA. Okay, they don't have DNA; it has RNA. So once it goes to these receptors, it really likes, which is your next little, let's see, right here, it binds to what receptors? These are the receptors it can bind one to. The one that it loves is the CCR5 receptor. I don't know what, they just really like that receptor. Infecting occurs first by entering the bloodstream. So here it is, it's hooked onto that receptor. Now, and this is called the docking process, okay? This is when it combines to the receptor, then here's where it actually fuses. So you see the word fusion? So that's going to be important with some of your medications because we have a medication that blocks that, so it cannot fuse to the cell. So here it is, it's fused. And then we have where it converts, so you can kind of go back and forth on those to kind of go in order. So then it converts from RNA to the DNA, the copy DNA. And the reason why it does that is that way our cell doesn't reject it, because if it stays as an RNA, what can it do? If an RNA doesn't convert, so it can kind of, like, have you ever seen those filters? What's it called? Catfish filters? No, nobody sees that on Facebook. So the catfish filter, so like it puts on a different face. It makes it look like what it's really not. It kind of tricks the cell. So then it can come in here and it can combine to our DNA, the DNA of the cell. Okay? So then this is called integrates. It's when it integrates into that other DNA. So then when it integrates, it forms this long protein strand here. And what it has to do with this, and you can see like the abnormal one is right here. So when it combines to our protein strand, then there's a process called protease that clips this strand into little tiny pieces. And the reason why it clips that strand is so that over time, our cell is here, here's our DNA, like all these little pieces. These little pieces will come down here and they'll get a hold of our membrane, like this, okay? Over time, it gets smaller, and then it starts coming here, and then it starts coming here, and then it bubbles off. And then what's it do when it bubbles off?
Goes to attack other.
Goes to attack other cells. So have you ever blown a bubble, and you have a big bubble with all the little bubbles around it? That's what it looks like. And then all those little bubbles let go, and then it starts going in and affecting all the other CD4s. So the process of this, if you can understand that, then you can say, okay, this medication, doesn't allow fusion to happen. This medication doesn't allow it to integrate into the other one. This medication doesn't allow the protease to happen. That's why those medications are important, and that's why this process is important, so that it can make sense when you're studying your medications. So I would definitely utilize that cell.
You said if RNA doesn't convert in something.
If RNA doesn't convert, then they can't do any of this.
Okay.
It can't integrate. If it doesn't
So in
convert,
other
it
words,
can't integrate.
that's too bad, or because if it didn't, then we wouldn't have as much to worry about with HIV.
Correct.
Right.
Right. Yeah. So, and the nice thing, there's 2 different medications that work against that part. So it blocks it from being able to do the reverse transcriptase. So that's what's nice. Okay. So what it does is it ultimately changes the CD4 T cell role in its immune defenses. So now it can no longer, at first, let me just say this, at first, can our immune system recognize it? Yeah, when it first infects us, our immune system can recognize most of them. However, one will slip in. To me, it kind of, women's health, I think of a little sperm slipping in and making its way through. One HIV particle can actually make its way to a CD4, and that's what starts that process. It overwhelms the system. So now our nice, beautiful CD4s that we used to have that work no longer work. Most of them are infected. So if our CD4, how we monitor our process of HIV is through our CD4 T cell count and our viral load. As this goes down, that means what? Is our immune system suppressed? Yes. Our viral load increases. What's that mean? If our viral load is high. Yes. So there's a certain number we look at. So when we test viral load, we'll see how many there are. If there's over 100,000 copies in our body, that means they are at a very high risk of transmitting this disease. The stages. So you have your 5 different stages. Stage 0 is that first positive after a negative. So I don't really touch you on this, so don't worry about it. So you have your first positive. So your first positive after an initial negative. A negative. Okay, so they have to wait about 6 months before they test your CD4 count. But I'm not saying they won't treat you, but they're going to wait about 6 months and then they'll tell you if their levels. Stage 1 is when your levels are around over 500. So that's an okay count. Okay. What you want to include in this is there is no AIDS defining characteristics. Stage 2, your CD4 is 200 or 99. Again, if it's not yet below 200, then we can say that no AIDS defining characteristics. Stage 3 is where they go below 200, and we may see those AIDS defining characteristics. And then stage unknown. Sorry, don't do. Y'all can copy it. Stage unknown is where we know, like this is a instance where you may be in an ER, patient comes in, they say we're going through their history, they say, okay, yeah, oh yeah, I have a history of HIV, and then we're like, okay, well, do you know what stage you're in? And they're like, no, I haven't really went back. So we don't really know. So we know that they've been on medications, they're positive, but we have no clue where they fall because they haven't had blood work forever. So we just don't know. I don't touch on that either. Big question. Once you have a diagnosis of AIDS, okay, so under 200, the CD4 cell count is below 200, and we recheck them, they're on medications for a while, and now it's 499. Does that mean they go back to HIV? No. Once they are diagnosed with AIDS, they still have that. Now we can help, their immune system. We can get their CD4, their regular ones, back up to where they should be. But once they have that diagnosis, we cannot revert that. Now, this is another important kind of saying that you should always remember. Everyone who has AIDS has HIV. Okay? But not everyone who has HIV has AIDS. because some people get those two terms confused. Okay, so we have early infection. So when people they may not even know they have HIV at first. They may actually have kind of like flu-like symptoms, like a cold or something that is there, but then they get well again. Okay, so because their body's kind of trying to take care of it, so then they feel okay again. But as time passes and those CD4 T cells start reducing more and more, then we see these things that kind of go along with it. We see the lymphocytopenia, we see the incomplete antibodies, because here we are, we're trying to make good antibodies, but our helper T cell is suppressed, so we're really not seeing good functional antibodies. We see an increased risk of those infections and malignancies. And we'll kind of go into more detail as we discuss this. Okay. So how is HIV transmitted? So breastfeeding, so there's a reason why, like, we do pregnancy screenings as soon as women come into our clinics. They really need, if we know somebody is HIV positive, we want them to actually go to an infection specialist right away. That way they can get help, get treatment, because there are medications they can take that can prevent that transmission over to the baby. I had a patient in Illinois. She came in one time to see me. We did screening on her. She was supposed to come up to her, back to her follow-up. Thankfully, I looked at her lab. She didn't come. But her lab work showed HIV positive. So we called her, we sent her letters, we ended up having to call the health department because nobody could get in contact with her. She only came to us because sometimes they can come to you, they can get their positive pregnancy screen, and then they can go to WIC and sign up for all that stuff. So I thought maybe she just went somewhere else. So 9 months later, thankfully, guess what I did? I documented everything, every call we made, every letter we sent, had all that documentation. But a physician calls, and he was mad. He screamed at me. He cussed me out. I said, well, I don't even know what you're talking about. He said, well, your patient is here. She's HIV positive. And I said, can you tell me her name? Like, so I know who you're talking about? So he tells me, I said, well, I can show you all of our documentation. We contacted her. We had the health department contact her. I said, she never came. So she never went anywhere else for any care for 9 months. So did she possibly transmit that to baby after she had baby? Yes, more than likely. So there's reasons why, this stuff is important. Sexual intercourse. So the highest risk of sexual activity, and even, for a long time in your books and everything, it says homosexual men. However, I want to argue that because women also have anal intercourse. Why is that such a riskier behavior? Why?
Because the tissue's more friable.
Yes.
And it fractures and
Yeah,
cuts.
the mucosa. So there are instances that, it's I like to tell people it's everywhere. So we have to be very cautious and educate strongly. So minority groups, injectable drug users. So we have seen increases kind of like in the Huntington area and stuff like that due to the IV drug use. Now, there's ways that we can prevent this stuff, but we're talking about how it's transmitted. So people kind of reusing their needles, people using other people's needles, children of HIV infected women. So, I educated, or I kind of talked a little bit, I think, maybe I did with you all. I can't remember. I don't think I did tell you guys this. But I had a patient that her and her daughter, yes I did, I remember saying this. Her and her daughter was using the same razor, and she had Hep C. So that's a no-no. So with HIV, we also strongly encourage moms or whatever not to use this, I guess. We say, don't do that. HIV is in the blood, the semen, vaginal secretions, things like that. We have to think of anywhere now, and I will say, the vagina, like those muscles and everything like that, are thicker, and we deliver babies out of them, right? However, I would say that would be kind of the next increased. Oral cancer, it decreases, but vaginal, because it can still, bleeding and all that stuff can occur. Can it happen? Can we transmit it through casual contact, through a kiss? No. Okay. So this is what I always tell people, and if you're taking care of a patient, I've heard this on floors and stuff, and people feel like they have to just automatically gotta put gloves on. Do you have to? If you're going in checking their heart, their lungs, stuff like that, you need to wear gloves. Don't do that. I mean, if that's kind of how you're germophobic, okay. But if you're somebody that typically doesn't, it can make somebody feel like crap. How to prevent the spread of HIV? Avoiding unprotected sexual intercourses, so anal, vaginal, and oral. Here's our ABCs to prevention of HIV. Abstinence. I heard somebody ask me, can we tell people that? Heck yeah, you can. It's not against anybody. You can definitely teach people about abstinence. Especially young people, things like that. I always talk about that. Being faithful, condom use. It's a barrier, right? So we want to educate on condom use. Don't laugh at me when I say this, because I've actually talked to people before, and there have been people that have admitted to me that they do this because they may live riskier lives, but latex gloves for foreplay. Sounds weird, I know, but give them a pair of gloves and, So that's things that you can do with patients. I know, it sounds silly. Avoid sharing needles. So I'm pretty sure they still have a needle exchange program out there, so we can educate patients on these kinds of things. And then standard precautions with healthcare. What does that mean? What are standard precautions? Yeah, that is when you glove up. You're doing something with your IV. I remember, oh my gosh, this was over 10 years ago. On 3 South, we had this patient that, I remember I came in on a night shift. I remember somebody said, just be careful with him because he tried to stick me with an IV. And I was like, oh crap, I'm nervous or whatever. He was really good to me. So I don't know what the issue was between them, but he was okay with me. But I was like shaking when I went in. I was a brand new nurse too. So the higher the blood level of HIV, the greater the risk for sexual transmission. Okay, or perinatal. So that is why we check the viral loads for these patients. Yes, CD4, we want to check that for immune system, but if we want to look at the transmission rate with these patients, we're looking at the viral load. HIV/AIDS cannot be transmitted through toilet seats, okay, sharing utensils, insect bites, anything like that. So, I think when patients hear this, they think, which I know. I don't like my kids sitting on toilet seats when we go out and about, because I don't. But as far as family members, things like that, it can't transmit like that. Pre-exposure prophylaxis. So there's a lot of commercials on Truvada. I think I've seen lately. I don't know if you guys have seen it, but it's on there, and it's for pre-exposure. So what are some instances we see pre-exposure?
Your partner is positive.
Right. That. What else? What about drug users? So they are higher risk. So we can definitely do stuff like that. We do have to do renal function tests every 3 months. We do that before we start giving this because it does have a lot of effect on our kidneys. High risk populations, we just went over those, so you can add those to your slide.
There's also a new injectable form of PrEP that I don't remember if they said they were seeking FDA approval or they had just got FDA approval, but instead of daily, it's only once every 3 months, I believe.
Oh, that's good.
So you don't have to worry about missing your dose. You just take your shot, come back in 3 months, take another one.
Kind of like Depo.
Yep.
So there you go. So a new one's coming out. So and that's probably better too, because, when I think of, like, especially educating young girls on, okay, can you remember your birth control pills? And they're like, I think, and I'm like, you have a cell phone? Yep, put it in there. Like, put your daily reminders. And so this is the same thing. You want to make sure that they're staying on their treatment and their regimen. So what situations could we see if we need to treat patients for exposure? So when do we see exposure happen?
We'll need needle sticks.
Yeah, so our occupation, right? What else? I'll give you all a break in a second. I had somebody text me earlier about being late for the specific reason, so I want to let her in because of it. So what else? Occupational, what else?
After one night stand.
Yeah, and even think of rape. I've seen a lot of girls in Illinois that were raped, and you know what it was from? Uber drivers. So be very cautious, or be with somebody, because she was by herself, the one that I talked to. And yeah. So usually the treatment that when we are doing treatment, 24 to 36 hours is when we say is a decent time to get the treatment. However, within 2 hours is the best, when we have the best outcome. Again, they'll continue doing periodic lab testing just to make sure renal function, all those things are fine. What else do they do when there's a rape victim besides HIV testing and medications?
Well, they do the rape kit, there's counseling, there's,
What other medications do we give?
you know, lots of things.
Plan B. We check for STDs. We go ahead and give them, things that we can cover. We go ahead and do that stuff. HIV progression. Wait, I'm going to give y'all a quick break. Go take a break. I about forgot.